Thank you for your kind introduction. My disclosures. So the presentation outline is going to look at the burden of disease. We'll talk about how we shift in chronic care of diseases, management of chronic care from specialist centers to primary care, looking at the various new models of care in the UK. And then I will talk briefly about the challenges and summarize. So the concept of primary care has been in existence since the 1920s, and we know that. So the UK, we started the NHS in 1948, and primary care has been a key component of it right from the beginning, to the extent that we see about 90 to 95% of all patient contacts in primary care, and about 80% of these are seen and discharged from the primary care setting. So you can begin to see that if you have a very organized primary care system where you do things right and manage 80% of your population health within the primary care setting, very few patients going to the specialty units will imply that you will save a lot of costs as a health economy. So the concept of primary care we've known since that long, since the 1920s, but it has become more focused on since the late 70s, following the Alma Mater Declaration. And we now have a situation where GPs, certainly in the UK, will have a patient list. It used to be about one GP looking after about 2,000 patients. Now it's about probably one GP has about 16,000 patients that they look after. And like I said, all the contacts, a lot of them are minor illness. And even the chronic conditions, you now have a situation where GPs specialize in chronic conditions, diabetes, heart failure, chronic kidney disease, COPD, and so on and so forth. And the whole idea is to manage these patients so well so that they don't get admitted with exacerbations or complications. And we have this mantra that it's a failure of a healthcare system if the first presentation of a chronic disease is to a specialist unit. When we were talking about this program, I think the question came whether we should focus on CKD as a chronic disease or we should look at patients with diabetes who have CKD. And we decided to look at diabetes and CKD. And I was excited when we decided to look at diabetes as a focus. And the reason for that is a patient with diabetes normally will have other chronic diseases clustering around the diabetes. So things like heart failure, obesity, liver disease, chronic kidney disease, arthritis, all of these conditions aggregate around diabetes. And so I do a lot of work in cardiometabolic medicine, and in this day and age, I mean, like the fellow GPs in the group, Peter and Joanne will tell you, we get pulled everywhere to talk about diabetes. And recent as we're now talking about heart failure, chronic kidney disease, obesity, and the next few years, I'm sure they'll be dragging us to talk about liver, NAFLD, and so on and so forth. Because every time there's a new intervention, GPs are called to do something different. And it's impossible for us to have guidelines for every single chronic disease. And so focusing on one disease area that has clusters of disease around it. And indeed, a lot of those chronic conditions that cluster around diabetes are what I'll call concomitant or concordant long-term conditions, in that the etiologies are shared by diabetes, and for that reason, the interventions seem to be similar. So if you can specialize in that area and address the other long-term conditions that cluster around diabetes, you will, in one clinical setting, be able to address multiple long-term conditions at the same time. And so chronic kidney disease is one of those. Some data will suggest about 40% of patients with diabetes will have some form of chronic kidney disease. So if you run a diabetes clinic properly, you will pick your patients there. Not least because the nephrologist will only get to see about 10% of the patients with chronic kidney disease. The vast majority of them will die of other reasons before reaching end-stage renal failure, where they need renal replacement therapy. 50% of those mortalities will be accounted for by cardiovascular disease, And we do that very well in primary care. We control the blood pressure, lipid control, smoking cessation, physical activity, and obesity. We do all of that very well in primary care to prevent cardiovascular disease. Infections, a third of patients will die of infections before they reach renal replacement therapy. And again, in primary care, we manage all the infections through vaccinations, immunizations, and also treating acute infections. So this is data from the UK looking at prevalence of diabetes, the 4 countries in the UK. You can see now we are around 5 million people with diabetes. And if you look at the 5 million people with diabetes, the cost of managing these patients, 80% of that is spent on managing the complications, not in the initial capital outlay in the drug purchasing, but 8% is managing complications such as chronic kidney disease, heart failure, and all the other complications of diabetes. And so I think to avoid these expenses, it's probably a good idea to focus on primary care, where what I normally describe as we focus on turning off the tap rather than wait until the patients get to the specialist unit where they just mop the water. So we do the initial hard work, and a lot of what I call investment is needed in the primary care setting to prevent this from happening. That doesn't happen, sadly. This is data, the most recent data from the UK, looking at the number of GPs, 27,000 GPs across the UK, 833 diabetologists, 750 nephrologists in the UK. How about nurses? We don't do this on our own. Our nurses are very, very instrumental when it comes to management of diabetes. We have 1,400 diabetes specialist nurses, most of whom are in specialist units, and only 27% of them work in primary care. Now, we have heard about the Hong Kong model where Juliana mentioned a few times that you need GPs, they need to speak to your doctor. Well, in the UK, it's actually changing. A lot of management of chronic diseases is not actually done by the GPs. Our nurses do a fantastic job, healthcare assistants, and recent times, pharmacists. We now have what we call clinical pharmacists who all work in primary care networks. And the last count we had about 4,500 clinical pharmacists working in primary care networks. And these ones are responsible for not just managing or reviewing medications. They actually do the monitoring, and they are clinically trained, and they do a lot of the things that GPs would normally do, including prescribing. And so they work collaboratively with the GPs, and we heard already this morning about horizontal integration. So that sort of multi-professional level horizontal integration between the nurses, the pharmacists, and the GPs is what is working very well in the UK now. And if you do need a help, you then go vertically and speak to your diabetologist, nephrologist, or cardiologist. And I'll show a schematic representation of this later. Data from America show that if you invest in primary care workforce, you actually improve outcomes tremendously. So in this data, basically what they're doing, what they did here is looked at the association of supplying 10 GPs or 10 specialists to the various healthcare systems to see the impact on the mortalities of various disease conditions. And as you can see from the chart, primary care investment is just as competitive as investing in specialist units. And indeed, the conclusion of the study actually suggested that every 10 additional primary care physicians per 100,000 population associated with a 52-day increase in the life expectancy compared to a 19-day increase in the life expectancy if you invested in specialist centers. So yeah, investing in primary care workforce will save you a lot of trouble further downstream. So this is how we now manage chronic disease, especially diabetes in the UK. Only about 5% of the cases will be in the specialist unit. 95% of all cases of diabetes, and indeed chronic kidney disease, we managed in the primary care setting. And so we upskill primary care colleagues to a level where they can safely manage these patients in the primary care setting. How do the specialists, fit into this model? Well, Partha Carr, who is our national specialty advisor in the UK, came up with this model first. We call it a Super 6 when it comes to diabetes. And so what Partha said back in the I think it's 2012 was that for a person with diabetes, if the person is on insulin pumps, they have antenatal needs, diabetes foot concerns low EGFR, uncontrolled type 1 diabetes, or an inpatient, they need to be managed in the hospital. Everybody else should be managed by the GPs in the primary care. And so you can imagine the vast majority of patients who have stable A1Cs do not need to see a specialist. All of them will be managed in primary care. And that worked very well because the specialists who are in the hospitals very busy with these Super 6 categories, they now can have time to discuss patients when the GPs phone them up and provide educational lectures and indeed sometimes help them with medication or patient reviews. And that is basically what the specialists do for their primary care colleagues who managed a lot of the stable patients in the primary care setting. In Leicester, where I work, we came up with a different model because these 6 cohorts of patients are not exhaustive enough in our opinion because there are some patients who do not actually fit these 6. So we came up with another group called the Super 7, and the Super 7 would include patients with type 2 diabetes who are complex, probably with severe morbid obesity, young type 2s who need special care, and people who are on multiple therapies yet not achieving control. So all of those patients we put in a Super 7 category, and our GPs manage those. The GPs don't do it themselves. They do it together with colleagues, nurses, pharmacists, which I've said already. And at the beginning of the model in Leicester, we did this systematic review where we looked at 60 studies across the world, close to 40,000 patients, looking at interventions which were targeted at primary care colleagues to see the benefits of these interventions. And what we found in the paper was that multifaceted professional interventions were more likely to lead to reductions in outcomes, especially A1C, compared to single interventions targeting single healthcare professionals. So if you choose an intervention such as healthcare professional education and you only educated GPs or nurses, that doesn't work. If you target the education to multiple healthcare professionals in the primary care setting, and not just education, but combining the education with other interventions such as audit and feedback, case management, and incentivization. All of those together, you are more likely to achieve benefits. And so this is a schematic representation of the horizontal and vertical integration. Horizontal integration is the first inner circle where you have the GP working with the diabetes nurses, the pharmacists, healthcare assistants, and the IT specialists in the primary care, all of them working around the patient. The patient is in the middle. And Joanne mentioned this earlier in the morning about the integration between the nurse and the GPs, where she suggested the nurse would do the search and then task the GP to address issues. So when I talk about multidisciplinary working, it's not feasible to have all of these healthcare professionals in one room at the same time with the patient in the middle. Even in the era of post-COVID, where we are virtual working, you cannot get the other clinicians log in at the same time on a Zoom call to do the consultation because of difficulties in synchronizing diaries. So the best way is to get one of them to take the lead. It might be the nurse or the pharmacist, to look at the patient's data on the system, highlight what you think as a healthcare professional will be the most pressing issue, and then list them. When the patient comes in to see the doctor, whoever they see next, they will discuss with the patient, see what their priorities are, and then from there you can address the issues. If you do need specialist help, then you can then call the nephrologist, the cardiologist, the podiatrist, or the psychologist, whoever you need. And this does not have to be a referral to an outpatient clinic, because that can take close to a year in some cases to get an appointment. It might just be an email to them for advice, and they'll give you the advice. So we looked at this model in Leicester, and we evaluated it in this cluster randomized study where we looked at 8 practices that were doing this model, and the other 8 practices just looking at standard of care. And what we did was, in the intervention practice, they had the holistic, panel of, interventions are listed. Incentivization is extremely important in the UK. You will not get work done if you don't intensify. We call it pay for performance. So that together with, audit and feedback, healthcare professional education, all of that together in the intervention practice versus the core practices. After just 12 months, we began to see improvements in non-elective bed days, admissions to secondary care units, and also first outpatient appointments were also decreased in both arms. And clinical outcomes significantly dropped just within 12 months. Things like admissions for cardiovascular disease and so on, all of them dropped in the intervention practices. So how does it fit into the CKD case? I've already mentioned that diabetes does not go alone. A lot of patients with diabetes will have other chronic kidney diseases. So this is a study that we recently published in Europe. And in this study, what we did was did a survey of all primary care clinicians across Europe. And we focused on their confidence in managing chronic kidney disease in the primary care setting. And 2 things that emerged from that survey was that clinicians in primary care, their confidence in diagnosing chronic kidney disease and staging chronic kidney disease are extremely important. In the first part of the, the first part of it, the first part of the first 3 bar charts you see, they are focused on diagnosis of chronic kidney disease. And here what you see is that those clinicians who say they were confident in diagnosing chronic kidney disease, they were several times more likely to know lifestyle management of chronic kidney disease and prescribing RAS blockage and prescribing SGLT2 inhibitors. And similarly, staging, those who were confident to stage chronic kidney disease were, in the case of providing lifestyle advice, they were 10 times more likely to provide the proper lifestyle advice. And similarly, they were more likely to prescribe RAS blockade and SGLT2 inhibitors. So if you have to undertake an intervention in the primary care setting on chronic kidney disease, just focus on improving their knowledge in diagnosing and staging, and you do a lot of things. Diagnosis of chronic kidney disease is normally by EGFR and ACR testing, but there are challenges, lack of funding, poor career structures in primary care, workload, infrastructure, and changes in the chronic disease burden in primary care makes it impossible for us to know all the guidelines when it comes to this. So specifically with ACR testing, in the same study, what we found was that only about 1/3 of the respondents suggested that they were confident in interpreting the ACR results, or they can teach it. That means 2/3 are not, which makes it difficult. So to pragmatically improve this, we now focus on a population-based ACR testing, which is now widespread across the UK and is funded by the NHS. And through this, what we do is basically get the patients who have the risk factors for chronic kidney disease. The GP supplies the data to a third party who mails kits out to the patient's home directly. The patients would do the testing in their homes, and then they send the results straight to the GP. If the GP sees the result that is abnormal, they invite the patients back in for a confirmatory test. And through that, in our pilot study in Leicester, we were able to have about 20,000 patients tested with this scheme. And from that, we're able to find a 4% reading of high abnormal patients. And this is interpreted to, leading to an estimated, end-stage renal disease of about 35 in just the 1 year. New cases, over 2,000 new cases of CKD was diagnosed based on this case. And the patients' feedback was fantastic. They loved it. 94% said it was very easy. 89% said they would recommend it to a friend, and 95% didn't remember encountering any problems doing it at all. How about training in primary care? We don't get enough structure, in primary care. So this is a study that we published a few years ago now, looking at research in primary care, and we don't get it. This is just funding for research on diabetes-related articles on PubMed. And what you find is that whereas over the past 20 years, funding for primary care research has been stagnant, specialist care funding for research has been increasing. Until you invest in primary care research, you're not going to address all the challenges that I've just talked about. Thank you very much for your attention.